Good morning, everyone. Thank you for joining us today for this important webinar. I think it's a really important topic, empowering parents in prevention and recovery. So I thank you for joining us. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. And as Greg mentioned earlier, you'll receive information at the end of this webinar on how to apply for that credit. This webinar has also been approved by NJOEMS for one EMT elective CEU, and that information on how to get your credit and how to sign in for that will also be available at the end of this webinar. The Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, and this program is eligible for a maximum of one Category A hour or CEU. So please be aware, again, that there are many different links for each type of credit that's being offered for this webinar, and make sure that you go to the correct link to apply for the credit that you need. And as noted on the slide, the links will be provided at the end of the webinar, and as I mentioned and Greg's mentioned, and in follow-up emails that you'll receive tomorrow. So hopefully it'll answer all of the questions that you have on your credit, but please, if not, you can reach out to us. Just some housekeeping. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson, and all other faculty and planners have nothing to disclose. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares, the Office of Alternative Community Response, and the New Jersey Office of the Attorney General, and the Opioid Education Foundation of America. And I thank them all for their partnership and support and collaboration for today's learning activity and throughout this year-long learning series. And I thank you all as well for joining us. I'm so pleased to welcome today's expert speakers. We've spoken about their presentations today a few times, and I think we're going to learn so much. First, we have Dr. Melissa Wallach, the Director of Medical Education at St. George's University Medical School Program and the Director of Quality Improvement of the Pediatric Primary Care Practice at Hackensack Meridian Health, and Lizette Lester, who's the Deputy Director of Case Practice in New Jersey for the Division of Child Protection and Permanency, DCP&P. And so I welcome both of our speakers. I thank you for being with us today. And Dr. Wallach, I'm going to turn the presentation over to you.
Good morning, and next slide, please. Thank you very much for that warm welcome. So today, my topic is talking to patients and parents, guardians about substance use in the pediatric primary care office. Next slide, please. I have no financial disclosures. Next slide, please. So our learning objectives are, number one, to identify the ways to speak with and guide parents and guardians to address the prevention of children's substance use and addiction. Number two, to identify the optimal treatment interventions and strategies that the care team can use to promote health and reduce substance use among adolescents. And finally, to identify the signs and symptoms of substance use in children and adolescents. Next slide, please. So a little background and why this topic is so important today. As we know, the third leading cause of death now under the age of 19 years is drug overdoses and poisonings. And to just give you a little bit of more perspective on that, in 2022, there was about 1,100 adolescents from age 14 to 18 years who died of an overdose. And that could be the equivalent of a high school classroom each week, just to put it into some more perspective. And fentanyl was a big contributor to that. It caused double the mortality rate from overdoses from 2019 to 2021. And 3/4 of adolescent overdose deaths are caused by fentanyl. And another interesting fact is that many of these fentanyl-related deaths occur in teens that don't have any identifiable risk factors. And that's why it's really important to do what's called universal screening, which I'm going to talk about later on. And interestingly, opioids are also found to be the leading cause of fatal poisonings in children under the age of 5 years. And just another point, the number one cause of death in this age group is firearm injuries. That includes death by suicide. And the number two is motor vehicle accidents. Next slide, please. Another interesting point is that many times there could be counterfeit prescriptions that can have fentanyl in them. So they can look like painkillers or benzodiazepines, but actually have fentanyl and be unknown to the person who's taking it. Another scary fact is that these are available for purchase on social media platforms. Another medication that we prescribe very often in the primary care office is medication for ADHD, stimulants such as methylphenidate or Ritalin, and this can also be contaminated with fentanyl. So many times people may be thinking that they're taking medications that they need for things like depression and anxiety, but really they have these counterfeit medications in hand. There are others who may be using fentanyl or intentionally for opioid use disorder. So we have to look at those folks as well. But a staggering fact is that 1 in 100 adolescents from 12 to 17 years of age have opioid use disorder. And many of these overdoses occur in the home of the child. They're often witnessed, but despite that, only 1 of 3 deaths have naloxone being used. So we need to educate families about how to avoid overdoses. Next slide, please. So I'm going to talk about some other substances. Alcohol is the most frequently used substance in the adolescent age group. And according to the 2019 Youth Risk Survey, 29% of high school students drank alcohol, 28% tried it by 8th grade, and 68% by 12th. And alcohol was contributing to 3,500 youths dying below the age of 21 years every year in this survey that was done. And 17% had reported riding in the car with someone under the influence, and 5% had admitted to driving themselves while under the influence in the past 30 days when the survey was done. Next slide, please. So physical, sexual violence, suicide, homicide, and other physical, mental, academic, and social problems are associated with alcohol use. But the good thing that we know is that if we delay the onset of use, we are able to decrease the incidence of alcohol use disorder. Next slide, please. Tobacco. According to the 2023 National Youth Survey on tobacco, 2% of high school and middle and high school students ever use tobacco, and about 10% currently. And that correlates to 6 million ever using and about 3 million currently using. So that's quite a few. There are different products that are varied in their use percentage, and those include things like e-cigarettes, regular cigarettes, hookahs, cigars, pipes, oral nicotine pouches, smokeless tobacco. And e-cigarette use was the most common one used for the last 10 years in a row. And about 25% of them reported daily use, with 30 of the past 30 days being quoted. Elf Bar was the most popular brand, and Fruit the most popular flavor. And the most popular device was the disposable e-cigarette device. Thank you. We're going to talk about cannabis. So cannabis use, according to the CDC in 2022, about 30% of high school seniors used it in the past year, 6% reporting daily use in the past 30 days. And just want to point out that 6% of 8th graders, 15% of 10th graders, 20% of 12th graders have vaped cannabis. So it goes down pretty young, as you can see. And interestingly, regular heavy use can have negative effects on the developing adolescent brain. We often don't think of cannabis affecting the brain in ways that other drugs can, but the adolescent brain does continue to develop until about age 25 years. And there have been studies that compared users to non-users and showed that cannabis users had lower rates of high school completion as well as college admittance, and also was associated with difficulty with learning, memory, and problem solving. Next slide, please. It also has been shown to decrease the attention span and coordination, and can cause problems both in the school setting and with their social lives. It could be associated with depression, social anxiety, and temporary psychosis. And it can impair driving due to slow reaction time, which is really important now that we know in our state of New Jersey, cannabis is legal for 21 and above, that we want to make sure that people are not driving under the influence of cannabis as well. It decreases coordination time, and there still is a potential for addiction. Next slide, please. So why is this important? Well, we want to screen for substance use, and it's really important to do universal screening. What does that mean? That means that every child over a certain age that comes into my office, regardless of who they are, where they're from, they get screened for substance use. Because as I pointed out in one of the first slides, we don't know. A lot of these people have no known risk factors before they are found to use substances. And it's our job as pediatricians to educate the parents and guardians we see to talk to their teenagers about the different substances and the risks of using them. Another interesting fact is that friends who use alcohol or substances have been shown to be increasing the risk of their using it. So in other words, the expression birds of a feather flock together. So we want to make sure that we find out, what the children that our children are hanging out with are doing, because we know that there is an association there. We want to set boundaries for our children, monitor them, and know who their friends are. We want to also importantly remind parents to keep any medications that they have locked away. I think it's the slides are off. So to keep their unused medications, dispose of any prescription medications that they haven't used, and the medications they're currently using, make sure they're secure and out of reach of the parents. Okay, next slide, please. So it is important to do this conversation partly alone with the patient and partly with the parents present. We want to, again, remind parents to talk to their children about overdose prevention. We want to educate them about how it's available on the market, about the counterfeit pills that I talked about earlier. But we don't want to fearmonger. We want to encourage our teens to be strong and safe, but we also want them to be able to identify what an overdose looks like. And specifically when we're talking about opioids, somnolence, decreased breath sounds, paleness, decreased or loss of consciousness, cyanosis, which is turning blue in the face, and how to treat it, call 911, and how to administer naloxone. Many states have Good Samaritan laws so that you can tell the teenagers that it's more important to call 911 and save someone and than worrying about getting caught having these illicit drugs on their person. Another interesting fact to know is that naloxone has little or no copay when prescribed, and it's also available over the counter, although it's more expensive that way, and many health departments distribute it for free. Next slide. So the American Academy of Pediatrics recommends, again, that we do universal screening in our offices for substance use with the use of a validated tool. It's important, like I said before, for the pediatrician to spend time alone with the patient to ask these questions. And it's really important at the beginning of the visit to let the parent or guardian know that this is something that we're going to do, and that we do this with every teenager that comes in. We're not, trying to make their child stand out in any way. There are sometimes parents and guardians that refuse to leave the room, and that's okay. You can still do some counseling. You just might have to tailor the way you ask the questions if the parent refuses to leave. But it is important to let them know that when they do disclose things, there is confidentiality that is protected. Next slide. So again, we want to tell the families that this is done universally. Their child is not being singled out. And I also tell the teens this every time. I'm like, you can tell your parents everything we talk about. I can't tell them anything without your permission. And there are a few exceptions to that, mainly if the life of the patient is at risk. Next slide. So how do we do this? We do annual screening as part of our social history. We use this mnemonic in our office called HEADS, which stands for Home, Education, Employment, Activities, Drug Use, Sex for Sexual Activity, Suicidality, and Safety. Again, it's ideally done confidentially. And even when you're doing it confidentially, it may be hard to ask the patient these questions directly. So you might want to say, how do you keep your friends safe? Or what are some things that your friends do? Or you could say, does anyone you know use drugs, smoke, vape, or drink alcohol? And you can even be more specific. Do you have any friends that use cannabis or weed, opioids, stimulants, whatever way you want to phrase it, so that if you don't want to directly say to the patient, do you do these things? And if they disclose it to you, you want to be supportive for them in their journey to stop, or at least decrease the use if they can't stop right away. Next slide, please. So we talk about confidentiality. Well, when do we break that confidentiality? Well, obviously, if the child's life is at risk, it's kind of straightforward. If someone admits to you, I'm thinking about hurting myself or taking my life by suicide. In that case, obviously, you right away have to tell the parent. You always have to, though, balance the losing the trust of your patient versus the harm that the patient may endure if you don't tell the guardian what's going on. And when it comes to drug use, it could be a little bit more complicated, right? Because there's different levels of safety risk. Like we said, if they're driving, that's another level of safety, right? You don't want them to drive themselves or somebody else under the influence. So it is important to try to encourage the patient themselves to give you that permission to disclose to their parent and guardian. And if you have a good relationship with your patient and you talk about them over time, you may not be able to convince them the first time that they tell you, but if they come back another time, you might say, hey, this is something we really need to get your parent involved with. And if your patient has a comorbid mental health condition, for example, that requires a psychiatric evaluation, you want to also link them to resources for that. And in New Jersey, we have the New Jersey Pediatric Psych Collaborative, which is a resource that pediatricians and family practice providers can use to connect the families and patients to these mental health resources in a pretty timely fashion. Remember, it's really important to educate on the unknown potency of drugs and the risk of mixing them with other substances. And so if you know your child is using, for example, one or two things together, make sure you don't mix opioids with benzodiazepines. And they do sell fentanyl test strips where they can put the drug in a cup of water and then put the test strip in to see if fentanyl is in there ahead of time before they take the substance. And again, it's not like we're trying to encourage them to use it, but if they're already using it, you want to make sure that they don't get something that has fentanyl in it. And I have references regarding these things in my slides going forward. Next slide, please. So another way you can screen is by using something called SBIRT, which is Screening, Brief Intervention, and Referral to Treatment. It was developed by SAMHSA, the Substance Abuse and Mental Health Service Administration, in the 1980s to address the misuse of substances. And it gives you an opportunity to intervene early with patients that already might have risky drug and alcohol use before it becomes severe. It's multifaceted, it's integrated in public health, and it, again, gives the access to early intervention treatment for people who have or who are at risk for substance use disorders. It can be used in primary care offices, emergency room departments. It can be taught at universities. It can be taught in resident physician training programs at hospitals. Next slide, please. So again, it's an evidence-based program. It identifies, its aim is to identify, decrease, and prevent problematic use and dependence on alcohol, tobacco, and illicit drugs. It can be given by licensed and non-licensed healthcare professionals in both clinical and non-clinical settings. It uses validated screening tools and algorithms to approach potentially problematic substance use. Next slide. So the first thing you do is you start with a pre-screen, which is a brief tool. One example of that is the S2BI, which stands for Screening to Brief Intervention. And I have a link for that in my reference slides, followed by a more extended standardized tool, such as the CRAFT, which I'm going to talk about in some upcoming slides. And that is what you do. So in other words, if the pre-screen shows a positive risk of use, then you would do a more extended screen such as the CRAFT. Brief intervention is just talking to them on ways that they can either reduce or discontinue the use, give them advice, set goals. For example, if someone admits to using alcohol and they're binge drinking, well, let's at least stop the binge drinking if we can't stop the alcohol use right away altogether. Brief treatment, use techniques from this intervention in a more comprehensive fashion. And finally, if you need to, refer to specialty treatment, for example, an addiction treatment program if necessary. Next slide. So the CRAFT stands for Car, Relax, Alone, Friends, Family, Forget, Trouble. It's a validated tool that we use to screen children from 12 to 21 years for substance use. It's free. It's in multiple languages. There are two versions, namely the 2.1 and the 2.1 plus N. And the difference between those is that the N1 has questions specifically on nicotine use and vaping. And both of these versions are able to be administered, self-administered, meaning that the child is given a paper, they check it off and fill it out, versus clinician administered, where the doctor or provider would read to the patient. Next slide, please. It has been approved by the American Academy of Pediatrics, and research has shown that it's more successful if you give the self-administered tool. So this is what you're seeing on the left-hand side of the slide is, and just in the interest of time, I don't think I'm going to be able to read it all out because I know we had a little late start with the technical glitches, but basically I'll just try to summarize the top address in the past 12 months on how many days did they, number one, sip alcohol, number two, use marijuana, and number three, any other substance to get high. If they put 0 for all three of those, then you go to number 4, which is the C for car, and stop. And that says, have you ridden in a car with someone or had been or yourself high while driving a car? Yes or no, and stop. So If they say anything other than 0 for the first 3 questions, then you have them fill out all 9 questions, and they're yes, no questions. And you can see R is for relax. You know, do you feel relaxed when you use alcohol? Do alcohol and drugs, do you use them when you're alone? Do you forget things when you're using? That's the first F. And then family, friends. Did they ever tell you to stop or cut down? And finally, T, have you gotten in trouble? And just for the scoring, so any yes response gets a point. And if it's 0 to 1, there's probably no problem. If it's 2 or more points, then that indicates that further intervention needs to be taken care of. Next slide, please. So again, this is the same tool, but it has the N on it. So that's if you clue into number 4, that says, do they use a vaping device that contains nicotine or other flavors or any other tobacco products? So in this example, you would still have them fill out as you did before. If they put 0 for all 4 boxes, then again, you just ask them if they've ever ridden in a car with someone under the influence and stop. If they answer anything other than 0 in any of the questions, you do the full screen. And if they answer 1 for number 4, if you go to the next slide, these questions show up. So then you would ask these 7 questions, which are specific for vaping and tobacco use. So again, in the interest of time, I'm not going to read them all out. You'll have access to these references later, but they basically are, dialing into specifics about vaping and the addiction to vaping, cravings around it. If you feel like you need to use it, and also, do they use it in school? Because we know a lot of the schools now are having problems with the bathrooms being used for vaping. Next slide, please. This is just an example to show you how it looks when it's read to instead of filled out. So in the interest of time, we can skip that. It's basically the same way of scoring. Okay, keep going. Next slide. Next slide, please. Next slide, please. So this is the bar graph that indicates the probability of a DSM-5 substance use disorder based on the Kraft score. So if you look at the slide on the left-hand side, if they have a score of 1, that means they have a 32% probability of a DSM-5 substance use disorder versus a score of 5 or 6 where they would have 100% odds of a substance use disorder. And the bottom part of the screen shows the 5 R's that you can use for talking points when you're counseling. And we want to use motivational interviewing, which means you're using open-ended questions to encourage the child to talk to you more about the topic. So again, if you read what it says on the left-hand side, first, we're going to review the results. Can you tell me more about that? Under recommend, as your doctor, I'm recommending that you don't use alcohol, nicotine, marijuana, because it can interfere with your learning. It could put you in a dangerous situation. And then the R for riding and driving, noting that many motor vehicle crashes can occur as a cause of death, and we want to make sure that we decrease that by decreasing use of substances. And response, there's different ways you can ask the question if they're a user versus non-user. And finally, believing, giving them sort of validation. I believe what you've said, that it takes to keep, from using it, and I'm going to help you receive that, achieve that goal of not using. Next slide. And this, again, in the interest of time, won't go into detail, but there's a contract for life that both the young person and parent can sign that's put out by the Students Against Destructive Decisions. It's basically a promise that both the child and the parent will not themselves use substances and drive, nor get into the car with anyone that's been using these substances. Next slide. Again, I don't probably have time to read this all, but this is another way that you can approach the topic of overdose prevention when you're talking to adolescents and family members. And this is specifically put out by someone who talks about opioids specifically. So you want to start a conversation. It gives you ideas on how to do that. It's important we talk about it. As you know, the #1 teen drug overdose has been increasing in and we want to talk to you about this and talking about specifically about fentanyl and about the counterfeit medications, what an overdose looks like, how to use naloxone. So these are all different tactics on how to broach these subjects with the families. Next slide. So finally, I just wanted to have a little bit of time to talk to you about warning signs as well as physical findings that are associated with substance use. So if you notice your child is changing in behavior, so they're suddenly hanging out with a new group of friends, they want to spend more time with people that you don't know, or they're making up really bad excuses for that. They're getting angry when you confront them with it. If they're withdrawing from family time, spending more time in their room alone, not going to family gatherings, missing family meals, not going to their usual activities or sporting events that they like to attend or participate in, if they're egregiously violating curfew and telling you in crazy phantasmal stories about why they're home late, these are all warning signs for you. Next slide. Again, psychotropic drugs can make them react in an extreme way. So if they're so a normal disagreement where they would act one way and now it's all sort of more intensified, that could be a sign that something's going on. Remember, alcohol can impair judgment, can slur speech. Their grades could be slipping. They could be missing class. They could be absent from school, and they could lose their own motivation and self-control. And how can that be seen? Well, with poor hygiene, they might start dressing slovenly, sometimes even steal to pay for these substances. They start to disrespect authority figures, may lie, may be secretive, and you can try to track them on emails and with cell phone and texts. Next slide. Again, they may be irrational, erratic. They could even threaten to hurt themselves or other people, be verbally abusive, threaten to run away, drop out of school, destroy property. They could have mood swings. All of a sudden, if your child's depressed, that may be a signal that they're using substances. Especially if they show again, like a loss of interest in their former hobbies and they become more isolated. Next slide. So again, this is where I'm almost at the end of my slide deck. So some physical findings that can indicate abuse. I kind of tried to put what they look like with the substance they're associated with for you. So bloodshot eyes could be marijuana, pinpoint pupils, opioids such as heroin, dilated pupils, more the stimulants, cocaine, amphetamines, sudden loss or gain of weight, poor oral hygiene. If you see needle tracks, nasal symptoms, if they're snorting substances, if they're scratching or picking at their skin, that could be a sign of withdrawal, but you always want to rule out medical causes as well. Fatigue, they could have moments of hyperexcitability followed by crashing. Also, they could be tired if they're not eating right. And of course, if they're possessing paraphernalia that's known to be associated with drugs, so foils, envelopes, pipes, bongs, vape pens, mirrors, needles, etc. Next slide. So again, my key takeaways for you are that overdose and drug use is so prevalent in the adolescent population, the third cause of death in this country right now in this age group. So it's a huge problem that we want to raise awareness about. And how do we pick this up? We need to do universal screening. We can't just say, oh, this child looks like they may be using drugs. Let's go talk to them. No, every child that walks into your office, you have to screen them. You have to use motivational interviewing. So that's open-ended questions. That's how you're going to get more information. And encourage the parents and guardians when they're out of the office to talk to the children about it. You're talking as a trusted physician adult, and let them do it as well. They're their parents. And also be alert for any warning signs or symptoms of substance use. And finally, as best as you can, connect families with resources. Next slide. I just have these two videos, which we're not going to play today. They're going to be links available to you. They're put out by the American Academy of Pediatrics healthychildren.org wing. They're really good to talk about how to do this in the office and at home. Next slide. There's just two of them. I think that's it. That was the end. Then it's up to, there's another one of these. And then my resources, my references is the next slide. And then finally, the next slide is just questions, which we're going to save to the end. So I just want to thank you for your time. And I'm sorry if I went over.
No worries. I think that it was a really comprehensive presentation, and appreciate your time today. As you mentioned, we're going to be taking questions at the end of our next presentation. And so thank you, Dr. Wallach. I'm now going to turn the presentation over to you, Lizette. Welcome.
Thank you. And so Dr. Wallach did a wonderful presentation on our adolescents. I will be focusing on our pediatric and infants. Next slide. And you can skip to the third slide, please. Oh. One more, two more, few back. It should be reducing accidental medication overdose. One more back. Yes, here we go. So individual intervention is necessary to reduce the pediatric overdose mortality. Over the past several years, overdose mortality has increased in the United States, growing from 16,849 deaths in 1999 to 70,630 in 2019, a change from 6.1% to 21.6% per 100,000 people. The research has shown that there have been several waves of overdose and drug-specific types from prescription opioids to heroin to fentanyl. Unintentional pediatric poisoning deaths spiked 37% in 2021, with 59 children under the age of 5 years old losing their lives after gaining access to prescribed illegal illicit drugs. The U.S. Consumer Safety Commission notes that African-American children suffer a higher rate of unintentional pediatric poisoning injuries, 21.4%, compared to being 15.8% of the U.S. population. The report also found that blood pressure medications, acetaminophen, antidepressants, laundry packets, and bleach are the 5 products most involved with unintentional pediatric poisonings. The Healthy People 2030 objective is to reduce ER visits for medication overdose to a target of 16.6%. It is currently at almost 18%. As we proceed in this presentation, our focus will be on how to educate our families and provide the resources that are currently available to promote safety and reduce medication overdose in children who reside in New Jersey. Next slide. It should, and I apologize, it seems as though these slides are out of order. It should be the pediatric accidental opioid overdose. Should be one before that. We can leave it here, and I can just talk about what. Yep, this is it. Thank you. The most common way statistics are currently kept on child mortality is through the Child Death Reviews, or CDRs. The Child Death Reviews occur in all 50 states and Washington, D.C., and are composed of a multidisciplinary team. The team consists of medical doctors, law enforcement, child protective services, social workers, clinicians, and medical examiners. These committees review pediatric fatalities and near fatalities to understand the factors leading to a child's death and use the information learned to facilitate new legislation, policy, or community resources. Most of the statistical data regarding child fatalities are received from these communities. As you will see here, opioids were the most common substance abuse contributing to poisoning deaths of children age 5 and younger. Over 2/5, 42%, occurred among infants aged 1 year, and most fatalities, 65%, occurred in the child's home. Of the 1/6 of children, 97 out of 581 had an open child protective services case at the time of death. Opioids were the most common substance contributing to death, followed by over-the-counter pain, cold, and allergy medications. For fatalities with circumstance data available, 18% were determined by the Child Death Reviews to be deliberate in nature, and 63% of these occurred in children aged over 2 years. Next slide. It should be the opioids are highly lethal for children. There it is. Oh, okay. So in 1970, with the passage of the Poison Prevention Packaging Act, required all medications to have child-resistant packaging to prevent unintentional poisoning in children. While this has aided in the reducing pediatric mortality from prescribed medication, the increase in recreational substances has impacted pediatric mortality. The most recent substance has been opioid exposure, and currently fentanyl has become a contributing factor. Research has shown that the opioid overdose does not affect one population over another and does not have a significant difference when factoring socioeconomic profiles. This problem reaches across broad segments of the United States population. Next slide. Should have the title of news. I apologize for the slides. There we go. Yep. Here we are. So as you can see, here are a few of the national cases of accidental drug overdoses. Next slide. Should be what we're seeing in New Jersey. There we go. In New Jersey, the Child Fatality Review Board reviews all near fatalities and fatalities. They decide which cases will be reviewed by the collaborative board. A reportable fatality means the death of a child who was under CPMP and supervision at the time of death, regardless of the cause of death. Who was not under CPMP supervision at the time of death, but the death appears to have been due to suspected or confirmed child abuse or neglect by his or her parent or caregiver. And when I refer to CPMP, I just want to make sure everyone understands that is the Child Protection and Permanency Department. A near fatality means that a child was placed in a serious or critical condition as a result of an act of abuse or neglect. The child's being placed in serious or critical condition must be classified by the treating physician, evidenced in the medical chart, or reflected in the hospital record. A medical provider's determination that the child is in serious or critical condition shall be accepted without further assessment by CPMP if the provider or hospital uses different terminology to describe patient conditions. A CPMP shall rely on the standard definitions provided by the American Hospital Association. Many of the cases in New Jersey were due to the child's access to illegal substances. We are currently in the process of completing a system that will be able to provide clearer data on fatalities, near fatalities, and we would like to include type of substance. We have seen opioid, fentanyl, and marijuana exposure the most to affect children, but there have been cases of alcohol ingestion, diabetic medication, and Benadryl. In addition to children under 5 being exposed, children in your preteen, teenage developmental stage have also been victims of overdose, both accidentally and intentionally to self-harm. Next slide is a substance-related child fatalities, near fatalities chart. Thank you. Here you see the New Jersey numbers of cases reported to the division. One factor that may play a role in inaccurate numbers is bias. In New Jersey, Black families receive a higher call volume to the child abuse hotline as opposed to white families. So could these numbers be higher? We don't know, but what we do know is race, socioeconomic status play a role in who gets called or labeled. The next slide should be working with families. If not, you can go to the up and away. There you go. Okay. So I believe that education and resources are key to helping families understand the risk, but also to be prepared. We speak to our families about electric outlet covers, safe sleep, gates to prevent falls down the stairs, safe storage of medications should be a top priority. Medical professionals should educate patients to have medication in the approved child-resistant packaging and keep all medications out of reach of children. One recommendation is to keep medication in a locked storage container, but still remembering to place high above a child's reach. If medications are no longer in use, they should be disposed of rather than left in the household, potentially allowing a child to have access. Many police departments or pharmacies offer a take-back program where medications can be dropped off and disposed of safely. Parents should be spoken to about ensuring any visitors to their home also abide by the safe storage of medications. If they have a personal handbag with medications stored inside, they should place their belongings away from a child's reach. Follow the household guidance for medication storage. In addition, visiting or traveling, parents should be asking the host if medications are stored correctly during travel. Medications should be kept in original packaging and also stored out of reach of children. The Up and Away program is the CADC's aim to reduce child overdose. As you can see here, it gives families different ways to make sure that they are understanding how to keep their medications up and away of from their children. Next slide. It should be on naloxone. If not, I can just speak about it. So I know that Dr. Wallach also has some information. Naloxone is an intervention from opioids overdose as an intervention, I apologize, from opioids overdose can also be a tool for parents. Naloxone can reverse the effects and save a child's life. Increasing availability and educating our caregivers of this medication resource can be a solution to the opioid overdose epidemic. While I'm not an expert in this subject, the New Jersey Stop Overdose Program in the Department of Human Services has ample information and resources to help medical professionals and families. Naloxone has been the #1 cause of reduction in fatalities in children. In many New Jersey towns, EMTs and law enforcement have access to naloxone and have used the medication to aid in a child's overdose and save lives. If a family is using prescribed opioids, methadone, or any other narcotic, informing them to speak to their physician about having naloxone as a preventative should be considered. There should be a tips slide.
I was gonna say, Lizette, it seems that there's an issue with some of the slides. Maybe you can
I
just
will be issuing you.
yeah, if you could just speak about the tips on this slide, I think
Okay,
would be
perfect.
helpful.
So some of the tips that were found from the Up and Away program, in addition to there is also one that is called Protective Initiative, all through the CADC, and their website is about talking to your guest. And some of these, and the reason I pulled some of these out is from some of the cases that we've seen at CPMP, where a family member or a visiting friend has come to the home with prescriptions in their purses or in their belongings, and children, of course, are active, have gotten into a handbag, and have had an overdose episode because of what they have found. So tell your guests inside homes with children, discussing keeping medicine in a safe place. While it may seem for some individuals, it may be difficult, it's also about the safety of their children. Reminding guests to keep purses, bags, or coats that have medicines in them up and away and out of sight when they're in your home. If you bring medicines with you to a home with young children, don't be shy about asking for a place to put your medicines that is out of reach and sight of curious young kids. Teaching your children, for our older population of children, about medicine safety. It's important for us to ensure that our children understand what medicine is and why you or another caregiver must be the one to give it to them. And never tell children that medicine is candy, even if they don't like to take their medicine, because then they may perceive medicine as a way, and any other medicine as a way of a so-called candy, and may take it and then have an overdose. Here are the click. Of course, if all your medicines are in child-resistant containers, making sure that they're clicked and they're put away. And then, of course, always leaving meds away. Never lose pills or liquid medicines out on a counter, table, or bedside. Our biggest takeaway from this is always making sure that our families, again, as Dr. Wallach said, it is not just certain families, all families, about the safe storage medication. Included with my slide are different resources and printouts that can be available to the families that you work with. And we would love for all of our community providers to have access to the flyers, and for our families to have access to the flyers. We talk about car seats, and we talk about, safety in the home. We also want to include this as part of a prevention effort to reduce our overdose in our infants and children. Thank you.
Thanks, Lizette. And I think that's such an important point that you ended on, because, we have so many prescribers on with us, and we have, it's having doctors, dentists, we have nurses, and we also have people in the community, right? We have educators, people in prevention and treatment, and we have parents, and it's like, what can community advocates, what can we do? And one thing can be sharing that information and sharing those resources, as you mentioned, just something as simple as, posting that flyer up. I know in our previous conversations, and then we mentioned that we have a lot of representatives from the faith-based community. I mean, how simple is that? You have an audience and you can simply share that life-saving information. So thanks so much for including that. And I think it was a great note to end on. And I know we have a lot of questions that have come up but Dr. Wallach, I'm going to go to you first with a question to give Lizette a second before we go on. You talked about adolescent use of cannabis and opioids. Can you talk about what is the best type of treatment, or what can be done, and where should people be referred to? Not necessarily a specific, organization, but what should they be looking for, whether it be parents who are on with us or prescribers who are giving that information to their patients?
So I mean, that is something that we struggle with a lot is, access to all different mental health, providers in general. So I mean, for me, personally, a lot of times I do use the New Jersey Pediatric Psych Collaborative, which I know we have some members on the phone, because they definitely help find different specific treatment programs. Obviously, there's different things that may cause you to send the child to the emergency room, but a lot of times that is not always necessary. Obviously, there is with cannabis, they can have a cyclic vomiting syndrome where they get dehydrated and they need to be hospitalized for that. So then probably following that hospitalization, they would get connected, hopefully to some resources to stop. But if you're just talking about, a little bit of mild use, it's obviously, talking to the child and talking to the parent. They have to be ready to and willing to want to do something about it. Because I have had a lot of teenagers with cannabis specifically that they're taking it to self-treat for they were formerly on ADHD medicines when they were younger, or they've had a little bit of depression, anxiety, and they're just like, oh yeah, I just smoke once in a while, it makes me, it does more than my Prozac did, or more than whatever, or they don't want to go to therapy, or they don't have time for therapy, and all these other things. And so, you have to have them willing to be able to make that change. I hope that answers your question. I know I could probably talk on and on about different examples that I've seen in the office with regard to that. One other little point about that though, because we did talk about counterfeit pills and things being laced with fentanyl. And I think I shared this story with Angela when we were doing the prep, was that I had a mom once tell me that she felt more comfortable now that it's, legal in our state to get the marijuana for her son, who she knew wasn't going to stop using it, rather than him getting it from another illegal way where it could be more likely laced with fentanyl and could cause risk. Now you might say,
That we have Lizette, you talked about diversion prevention, which I think is so important. Dr. Wallach and Lizette, you both talked about that. What do you talk to parents about, Dr. Wallach, about that securing the medicines in the home, and the conversations that they're having with their children? And Lizette, if you could add to that about, some things that are so important. I know you touched on it, but if you could add to that. So, Dr. Wallach.
Yes, I mean, we want to remind parents, you could go for a gallbladder surgery and get prescribed, a few, some opioids, and you may not use them all, or even while you're currently using them. It's really important to make sure for both the adolescent and for the young children that Lisette spoke about, because and I love the fact that you talked about the candy thing, because that is, so many times when we prescribe medicine, you hear the parents saying, oh, don't worry, it's just like candy, it tastes good. It's like, no, don't say that. Like, you don't want them to make that association. And the other point that Lisette made, which is so important, is it can't just have the child lock. It has to be out of reach, because there are some very savvy kids that can break, little ones. I'm not even talking about the adolescents that may be intentionally trying to use something, but the little ones, they can figure out how to open it. So you really have to have it out of reach. So and just reminding them that all these things are out there. I mean, I personally don't have that much firsthand experience with opioids, but I do. In preparing for this, learned a lot about naloxone, and the fact that that's why those videos that I did have, that doctor, he's someone who is firsthand experienced with it. I think he does a really good job describing how to talk to your children, as well as how doctors can talk to patients about it, just to know that it is over the counter. Even if you, like, for example, if I didn't want to prescribe it myself, I could at least say it's over the counter. Make sure, like, if you're, like, for example, you have a mom that's on methadone, and she's, she has to take that for her use disorder, at least have the naloxone handy, just in case someone who shouldn't get the methadone gets it. I don't want to let Lisette answer too. I feel like
No, yes, Lizette, please.
And no, Dr. Wallach, you were perfect. That's exactly what we want to be able to do. We, part of that is, understanding that we're going to have families that are going through different situations, and And for a family or a parent on methadone or receiving opioids, you know, kind of not normalizing it, but normalizing the fact that you have this, and this is what we're going to do to make sure that we can try, at least that prevention is key. And, you know, it's a very, sometimes it can be very uncomfortable, but it does that uncomfortable conversation then prevent an event, you know, and we've seen so many different prevention events. So now it's no, don't leave your children in hot cars, you know, the pool preventions that we've seen and how that does reduce. There are always going to be, unfortunately, accidents that occur, but, you know, one of the things that we want to do is continue this conversation about making sure that we are keeping our medication safe, because, and as you were saying with our adolescents, one of the things that we have seen, or I have seen, I should say, in my 24 years with the division, is oftentimes when we're speaking to parents about what happened, where did you get to this point of heroin abuse? It starts with, at my house, at my grandmother's house, there was access to an opioid. And so I used it. And then it proceeds from there. And so it is that ability to try to, as much as we possibly can in this current time and place, try to prevent that access to those medications.
You know, that's so significant that you said that, because when we first started talking about this opioid crisis, probably about 15 years ago, we were talking about that, about diversion prevention. And at the Partnership for a Drug Free New Jersey, we launched a campaign, Grandma's Stash. And it was, you know, who knew what grandma had in her medicine cabinet? And that's evolved to, you know, 5 steps about taking inventory of what's in the home, right? Know what you have, which prescriptions you have, and safely securing what you need to keep and safely disposing what you no longer need, and making sure that you have those conversations with your children, with which, you know, you both talked about. I know we put some information in the chat about the American Medicine Chest Challenge, and that is the second Saturday in November each year nationally and in New Jersey. And there's some information on there about on that website link about how to find disposal locations that are safe, as well as those tips that you can share, like you mentioned earlier, Lizette, just sharing them, you know, with others. We're coming to the end of our time. Before I go to both of you to let you just give one last comment for all of those who are on with us, I just want to mention that the links that you see on the screen are how you can access your credit. They are not hyperlinks. You need to copy them down and go to those links. You'll also receive them in your post-event emails. But just wanted to make a mention of that, because I see there's some mention of it in the chat. But Dr. Wallach, I'll go to you first, and then Lizette, I'll give you the last comment. But we have, as you know, everyone on with us today, one thing that you wish for them to take with them, one most important point.
Well, I first just wanted to thank you for the opportunity to give this presentation, and I appreciate everyone's time in listening and hopefully learning something from what I said. But I think the most important thing to do is to take away is to learn how to talk to your children, but also to learn how to talk to your pediatrician, and also permit them to talk to your child. So if they do ask you in a polite way to have some time alone, know that we're doing this for their well-being, and not to be secretive or anything like that. I think that's really, really important. I think it's a huge part of the adolescent visit, is that ability to talk to the children alone about this and other things that they may be going through, whether it's questions about their body, questions about their identity, questions about their mental wellness. And I think this is all really important. So thank you. That's my take home.
No, thanks so much. Again, your presentation was full of really important information, and those screening tools that you mentioned in the videos, like we shared, there'll be copies of that presentation available for everyone. So thank you, Dr. Wallach. And Lizette will give you the final word.
So thank you, everyone. And so along with Dr. Wallach, my final takeaway is that for everyone here, you are seen as an expert for many of our families. You are seen as someone that they can trust, as someone that they can go to. And so please remember that if you're providing this information from a trust-based, listen, this is what we're doing this. Even if this doesn't pertain to you, it may pertain to someone in your family. And as a person who loves to educate others, what I always say is, you may not need this, but you may know someone who does. And so it's sharing that so that our communities can have that information and that education to be able to provide to other community, other families, other friends. And so please continue to, you know, have that information readily available to everyone that you may come across, so that they have this to share with one another.
Right, that's a great point to end on. So once again, I want to thank our presenters. I want to thank all of our attendees for joining us. I know we're at the end of July, and these are great days if you're in an area around the country with great weather. So for you to take the hour and join us today, we appreciate it. Thank you again, and I hope that you will join us for our upcoming webinar, Understanding and Supporting Recovery. So thanks, everybody. Have a good day.